Okay, so we had met with our panelists before today, and we landed on a couple of, I think, very provocative questions. And I'm just going to read them, and then I'm going to ask each of the speakers to just take a few minutes from their perspective to situate themselves and then to answer the question. So the first question is, what is the pandemic teaching us about health equity and about public health? Thus my mentioning of the number of people that are here from public health. And then the second part of the question is, how do we carry those lessons forward? The title of today's conversation is The Way Forward. So what is the pandemic teaching us? And you can also use that chat box to add your thoughts, your remarks, your questions around that. And I'm going to start with Arne Ruckert. And Arne is a senior research associate, and we're really, really happy to have him here with us today at the University of Ottawa School of Epidemiology and Public Health. And he's also the research coordinator for the Global One Health Network. And he recently was very instrumental and led the way in publishing a paper, and I think that's going to be the basis of what he's sharing with us here today, a paper titled The Canadian Policy Response to COVID-19, What's in It for Health Equity? So Arne, I'm going to ask you to make your comments in response to our questions about what the pandemic is teaching us and how do we carry those lessons forward. So over to you, Arne.
Thanks, Claire, for the introduction and also for giving me the opportunity to be part of this conversation here today. I would like to also acknowledge that the land from which I present is the traditional unceded territory of the Algonquian Anishinaabe people. My short presentation here today will make 3 points, each related to the 3 guiding questions of this event. But before I engage with these specific questions, I also want to mention that you can find this report that Claire just described on the website of the Global One Health Network. And I will also put in the chat box later a link to the report, because it's obviously good to share these types of findings. It's a fairly lengthy report, but there's a bit of an executive summary, like a 10-page executive summary of a 100-page report roughly. So to get started, I want to reflect briefly on what the pandemic is teaching us. And I think the most important lesson is quite obvious, that pandemics are harder to control in the context of existing health inequities. And you can clearly see this in the global data. Countries and regions that are struggling with deep and widespread social inequalities are performing worse than countries and regions that have more equitable social structures and strong social support systems in place. This can be shown by comparing the Gini coefficient, for example, which essentially measures income inequality, to mortality per 100,000 population data. And if you do that, you will find that countries with higher income inequality, for example, the US, Brazil, or the UK, have much higher levels of mortality per 100,000 population than countries with lower levels of income inequality and stronger social support systems. Think of the Scandinavian countries here or some of the other European countries with stronger social support systems. But we also find that within countries, communities with lower income levels are much more likely to be exposed to coronavirus, and poor Canadians are much more likely to die from it. In Canada, racialized communities that are overrepresented in poorly paid essential jobs, for example, make up close to 80% of all hospitalized patients in Toronto, but only around 50% of the total population. And it is important to highlight that these inequities are not just related to how the health system operates, but rather to the broader structures of oppression and exploitation, what we usually call the social determinants of health in public health, that are defining the neoliberal development model that has become hegemonic in the 1980s and has remained hegemonic throughout the last 40 years, I would say. This leads me to my next point, which is that we need better data on how health inequities are experienced during the pandemic by various population groups. A particular issue in Canada is the lack of comprehensive data on racialized communities. We currently have to combine multiple data sets, such as public health unit case data and postal code-based census data, to produce useful information on health inequities for racialized communities at the population level, and that's just not good enough. My final point in relation to the first question is of what we learned is that we need to better target support to those that need it most. And it's understandable that we didn't have maybe the time initially to target it well. But I'm thinking here particularly of Indigenous communities that, while facing unique challenges in this pandemic, received on a per capita basis less financial support than non-Indigenous communities to respond to the pandemic. And so there's just something wrong about, you know, this relationship between those that are hit the hardest not getting the largest amount of resources. The second guiding question is about how we can carry forward the lessons we learned. And in my mind, the easiest way to do this is to massively invest in the various pathways that determine social determinants of health outcomes. So we need to investments in income protections, for example. The majority of Canadians are not covered by employment insurance. So if you lose a job in Canada, the majority of Canadians will not get employment insurance and will receive zero income support. And to some extent, this has started to happen during the pandemic, that we have revised, for example, employment insurance. And of course, we saw the introduction of the CERB, the Canadian Emergency Response Benefit. CERB is arguably the biggest social investment in recent Canadian history. And it has protected the health of Canadians by addressing the most important social determinants of health challenge in this crisis, which is a massive decline in income related to lockdowns. And CERB also had an enormous impact on the other social determinants of health pathways in this country, as income, of course, strongly influences other types of social determinants. For example, food security has increased dramatically after CERB was introduced. Most of you would probably think that food security has been a challenge throughout the pandemic, but it has actually been improved. If you look at Food Banks Canada data, it shows a steep decline in the need by citizens to access food banks and a sharp rise in the experienced food security in the wider population. But the change we need to see is about more than just protecting income. We really need to rethink and reinvent our entire social welfare infrastructure to address the wider social inequalities in society that are driving health inequities. In other words, we need massive social investments to rebuild the social infrastructure that has been destroyed really over the last 40 years of neoliberal austerity. To give you just one example here of particularly relevance to this pandemic, do you know that Ontario today has half the number of ICU beds that it had in the 1990s? On a per capita basis, it's around it's not quite half, but it's still a dramatic reduction in ICU capacity over the last 40 years. There simply would be less of a risk of hospitals running out of beds if we had maintained a proper health infrastructure in this country. Now, some of you might be saying, how can we afford this? And this leads me to the third question of what are the remaining unanswered questions? And I have two here. How can we afford this is the first one. But it actually doesn't need to be remain unanswered, because how we can afford the type of massive investment, I have a simple answer. We can easily afford it if we fairly tax everybody in this country. You probably don't know that CEOs don't pay income tax in this country on their income. This was something that Trudeau was going to address, because CEOs derive most of their income through what's called capital gains taxes, capital gains on shares, through share options. They get options in shares that they then sell, and then they derive their income from the gains in the share price. This is not taxed as income in Canada. Trudeau said he would tax it. So CEOs don't pay any taxes on most of their income in this country. And this is just a single simple example for how incredibly unfair our taxation system has become. There's tax loopholes for corporations, there's tax avoidance schemes. I can go on and on talking about how we need to restructure our tax system so that we can generate the capacity, the state capacity to actually invest in all of these crucial social infrastructure investments that we need to address social terms of health pathways. In other words, if we want health equity, we need to find a way to generate the resources necessary to put in place the social investments we need. This means that we clearly need to go beyond the boundaries of public health to engage with the political process and advocate together with non-health sector partners to design a just and sustainable future. And this includes the need for PHAC to be or to become a much more openly political actor in both its messaging and framing of issues, to explicitly link social determinants of health with the need for social investment to be driven by a more just and fair taxation system. And also through linking it to a whole of government approach, where we have to make sure that all the different aspects across the government landscape are in sync and work with each other to address health inequities. And I will leave it at that for now. Thanks.
Thank you, Arne. Thank you for a very comprehensive answer. I'm going to ask Sume and Louis, I got a little notification from the French language interpreters. If you could speak a little slower, then they can keep up. That was a lot of information there. But, you know, I heard equity matters, data matters, and there are solutions. So thanks a lot, Arne. I'm going to go now to Louis. Louis, is the co-chair, as we said, of our advisory board, and he's a leader in health equity in his community in Manitoba and in Canada. Louis is a wise leader, and he always shares an inspiring and action-oriented perspective. So Louis, what, from your perspective, is the pandemic teaching us about health equity and about public health? And how are we going to carry those lessons forward? Louis.
Thank you, Claire, and thank you, Arne, for your words. I've taken a lot of notes here because there's a lot to think about from what you've shared, and I'm grateful for that. I have been working in many ways in different communities at different levels for all of my adult life and in my career life. And that journey has taken me to different communities, different stakeholders, different circles of caring, different levels of thinking. And I always come back to trying to situate myself in the margins. It's part of my spirit name, Red Buffalo Man, where it's my duty to sit in the margins in order to be distant somewhat from the center of things, in order to be an observer and someone to reflect back to those who are trying to do the work, to be able to find the solutions that are sustainable for themselves. As I listened to this conversation and as I reflected on the questions that we've been asked to wrestle with or to think about, I was reminded, and I keep reminding myself, that this wasn't the first time for people who are living in the margins of our society. And so I look back at when we first started talking over a year ago about this pandemic. And for marginalized communities, few things came forward. Some of the first responses for marginalized communities that I sat with was that this wasn't going to affect us because we were living in the margins already, and especially people who geographically are distant from the epicenter of viruses and cities and those kind of environments. We will be protected. And I saw that in the era of AIDS, HIV, whereby Indigenous people did not think that this was going to affect them, that they were safe because they were in the margins. And that is a false hope, because we realize that geography is not a wall. It's in fact very porous, and once it comes into the circle, people are affected so deeply by these events and stuff. And the pandemic was one of those situations. And the other thing that I heard from Indigenous peoples in the beginning was that they were not in control of solutions. They were at the mercy of others to be generous or to be thinking of themselves. So they had to speak forward. They had to come forward. They had to speak loudly. And this wasn't new for them, to fight in a way for their entitlements, to fight for their dignity, for their sense of ownership and control and stuff. And this wasn't a new battle. This is an ongoing series of interactions with those in power, those in privilege, and those in control, and those of resources and decision making. To this day, many Indigenous peoples, and I think other marginalized communities as well, are sometimes consulted, sometimes asked for advice, but never in control of the solutions. Never the decision maker, never having the power to actually implement directly with the resources that they need. They're still in the margins around the resources that they will need because of the inequity that's embedded into their livelihoods, embedded into their communities. That's one of the teachings that we noticed. That's one of the things that we realized through these discussions that we've been having, but other discussions as well, is that it's a real challenge for people who are living with marginalization, and marginalization due to racialization and colonization. And one of the things that I hope this pandemic has brought to light is the structural is the social, is the pillars and foundations of colonization and in this country that still exists. And in times of crisis, you're responding so quickly that you don't have, those in power don't have time to protect their perspectives and bury them in fancy language. It becomes exposed really quickly about how things are done. So when Métis people are not considered Indigenous people of Canada and are left out, then you realize that there's still a very strong racial foundation to decision-making and power in this country, and they have to fight just to be at the table. That consumes so much energy. And we know very much in this country that there's still a lot of structural colonization going on through policy setting. And we've the long-standing historical argument of scarcity in this country as a reason why we don't act on things is a false truth. Just for this reason that in the times of pandemic, the money shows up. And we've been in a pandemic state for so long on so many issues. When you look at 50% of our communities still not having potable water, drinkable water sources, and there's no money, and all of a sudden when it affects the majority, then all of a sudden the money shows up. But it's not, it's very, very interesting. And Indigenous people realized that and saw that. And I hope the broader community as well saw that. So when we talk about having better data, I think one of the things that will give us the better data as we move forward is the need for us to stop and listen rather than talk. And we, as institutions, as organizations, as leaders, it's when we are still that we hear the truth. It's not then when we walk and talk and think we're listening, but we're just in movement that we actually hear the truth. We have to stop and listen in a deep way, because that moment of stillness creates space for others to feel comfortable and safe in sharing their truths and their truth to power. And as well will create opportunities for us to become allies. And that is very, very important. And in our learning and moving forward is to create a deep sense of alliance with relations to those who have been marginalized, again, through the pandemic, and their vulnerabilities have actually been, as Arne said, their vulnerabilities and the recovery will be much more difficult for those in the margins, for those communities and individuals. And that the other point I make to that is that the data has to reinforce the power of relationships and community more than individual states, because the solutions cannot be individualized, meaning you are responsible for your recovery as an individual, and therefore if you fail, it's your fault. And we apply that to many of Indigenous peoples and communities as well. We don't resource and we don't support, and we're not allies, and they have no decision-making abilities as well. So the pandemic will continue to teach us things. We have to listen to it, and we are the historians of public health. What we write today will have meaning, should have meaning tomorrow. Should not just be a reflection of the past. It should be in a way a call to action in every word that we use in order to move people through the power of evidence, but through the power of the stories where that evidence lives. And so that is our responsibility. So I'll leave it to that as far as some generic. We'll have more opportunity to talk more specifically on some of the elements.
Thanks so much, Louis. And that notion of listening, even listening to better data, or the story that data and information tell us, has been a bit of a theme throughout these conversations, that not just hearing, but actually deep listening and sitting, as you said, quiet or calm is what I heard you say there. I'm going to go to Sume now, but I'm actually going to ask the folks in the audience, our participants, to be thinking about questions and to go ahead and use that chat box to ask your questions. Claire O'Gorman, one of our knowledge translation specialists, is going to be watching the chat box and may combine a couple of questions when we come back to it. But Sume Ndumbe-Eyoh is one of our own at the National Collaborating Center for Determinants of Health. She's our senior knowledge translation specialist, and Sume very, very ably moderated the first conversation series, so you'll see her in those videos last spring. Out of which, under her leadership, we published a paper titled Back to Better, and that actually came from one of the speakers within that conversation series, amplifying health equity and determinants of health perspectives during the COVID-19 pandemic. So Sume, I'm going to ask you to answer that question now. What is the pandemic teaching us about health equity and about public health? And how do we carry those lessons forward? And over to you, Sume.
Thank you, Claire. Hi, everyone. It is a pleasure to be part of today's conversation. I am speaking to you today from Montreal, Jajaiga, the traditional homeland of the Ginengahaga Nation. I think those are really great questions to continue this conversation. A lot of synergy in terms of what I've been thinking and what I'm hearing from the two other speakers. I think I want to start us off with this quote from Stuart Hall, who was a Jamaican British sociologist, and he said, "Crises are a moment of potential change, but the nature of their resolution is not a given." So I think it's clear that we are in a crisis. We continue to live through this, and we're all experiencing the pandemic in very distinct ways. Also remembering that for a lot of us on the line, these are not just it's not just work, it is real life. As we're coming on, some of the panelists were saying, our work changed because, we had other responsibilities, we had family responsibilities. I think a lot of us on the line have lost people to the COVID-19 pandemic. I know I have. So these are not just intellectual conversations, they are very real live conversations with implications for our lives. So I think for me, the first starting point is that we're living through multiple pandemics, the COVID-19 pandemics, ongoing, colonial violence, ongoing racism. Really great to have Arne talk about the neoliberal logics, which are really shaping and defining how our societies and our economies are organized. So these are things which predated COVID-19. And once this pandemic, as we know it today, is gone, those are the things which will remain with us. So for me, in terms of our history of big questions, how are we going to rethink the social systems which were put in place, and how we're going to create some of what Louis and Arne are speaking to. So I think one of the things just come through in the COVID-19 pandemic is this increase on the global uprisings against structural racism. I think these two things have given us a real opportunity for a number of reasons. One, more of us have been impacted by both the pandemic and the uprisings against structural racism. So I think in terms of our public consciousness, particularly for those of us who hold privileges of different forms, because that's really what needs to shift. Derek Bell, who is a critical race theorist, talks about the fact that if we want to see a shift in terms of structural racism, right, white folks have to get on board because that's where the power lies. So I think similar with the pandemic, more people who are in positions of power and privilege are experiencing the downsides. Even those of us who feel like we're in relatively secure positions are still experiencing the impact of some of the pandemic. So I think that increased consciousness is good. The other thing which I think the pandemic is teaching us is that as a field, we don't learn very well from our history. Pandemics are not new in public health. We have experienced pandemics before, and if you go through the history of pandemics, what we see fairly consistently is that those are the margins get hit most significantly. So if I reflect back to some of the conversations which we hosted about this time last year, that came through very clearly. Louis joined us for that conversation, as did Claire and a lot of other folks, some of whom may be on the line today. And what came up very clearly and very powerfully was that we were going to see the kinds of fissures we're seeing today, right? So even though we know that, we still did not design our pandemic responses with that in mind. So if I recall some of the very early guidance which was coming out, and we're still seeing that, right? If you think about the fact that right now some of the main public health questions are around the vaccine rollout. Are we bringing an equity lens to that? I would say no. I would say that communities, a lot of communities are still actively advocating for being a priority in terms of how that vaccine rollout is going. So shout out to some colleagues in Ontario, like the Black Physicians Association of Ontario, who's actively working with the government and with public health to actually develop community responsive solutions to the vaccine rollout as a way of addressing the deep distrust and mistrust communities legitimately have in the system. So my question is, why have we not, as a public health system, had those conversations before now? Why are we still waiting for communities to drive those and to continue to advocate, even in the midst of the pandemic? I think the second thing for me, which the pandemic is teaching us, is the importance of community and the importance of resistance from a community perspective. Early on, in the absence of a concerted government response and public health response, which was really explicit about equity, we saw communities come together in terms of things like mutual aid. And so I don't think things like mutual aid can actually substitute ongoing sustained government intervention. But I think even in the absence of that, we saw communities actually create solutions to meet their own needs. And also this resistance. In terms of resistance, I think one of the other forms of resistance we're seeing is around this question of data. So I and other colleagues, and many of you on the line, have been involved in questions around data and really calling for better disaggregated data. But one of the questions which remains for me is, what does data do? So I think as a field, we have to understand that data is just one of many things which influences decision making. And so the evidence itself, in the form of specific quantitative data, because that's how we limit it in these conversations, I find, it's not enough to change and to influence decision making. So in the paper Claire mentioned, one of the things which we talked about as emerging from our conversations from last year is really the importance of drawing on social movement theories and system theories, and speaking to some of what I was hearing both from Lou and Arne around, are really taking advantage of this political opportunities, and in doing so, developing frames and narratives which really help shift decision making. In terms of public health specifically, we often say that, yes, we need to collaborate with other sectors, but they are things which are firmly within our own domain. And are we doing those things? One opportunity, I think, for us, which is coming forth quite clearly, is that within public health itself, we need to be investing in a public health policy and advocacy infrastructure which sits firmly within health, and that starts from training, how we train public health practitioners and decision makers from the very beginning, and how we resource our public health system to actually participate in policy advocacy as a legitimate part of policy practice. I'll give you an example of something which I'm seeing, and this is from a major public health unit, where we're seeing the data emerge around inequities. And I'm reading on their website. You can go find it for yourself here. And it says, the reasons for this is unclear. And they're referring to the inequities which we're seeing. How can we be saying that the reasons for the inequities are unclear? So to me, that's a really missed opportunity in terms of how we frame the message, because the way I would frame that is, this is not a surprise. The reasons for this are quite clear, well documented and established. And guess what? Even better, we know what to do about these, right? And we've heard some of those solutions come forth. So I think we need to do a better job at putting forth compelling narratives and resourcing our system. So sometimes when I talk about health equity, I often ask, what can we do to achieve the worst possible result? And for those of you interested in facilitation, this is called TRIZ. What can you do to ensure the worst possible results? Usually when I ask this question, people start to laugh, and it's like, we all get that knowing smile. And then we start to develop those lists. And then the next question is, what are we doing right now which looks like that first list? Those lists are eerily similar. So I think as practitioners, as policymakers, as decision makers, we know that a lot of what we're doing, some of what we're doing works really well, but a lot of what we're doing is not very well aligned to health equity, and which means that those are the things which we need to start to let go of and really give up. And until we give those things up, we will not be able to replace them with more equitable policy approaches. So in terms of, I think, potential areas of investment, we've heard some already. I just want to raise this idea, climate change, because we've seen that already. I think as we're thinking about addressing social and economic inequities, we need to be paying attention to climate change. Childcare has come up in a number of conversations as an area of investment. affordable housing, right? In the last year, housing has gone up 25% in terms of house prices. And this is in a full-on pandemic, 25%. In a situation where in large cities like Toronto and other places, housing was already so unaffordable, and we're seeing it going up. So how does the government start to come in to regulate the housing market, I think remains an important question. As a field, we need to continue our advocacy around dignified work, so conversations around paid sick leave, thrive in wages, again, invest in things like mental health, conversations around prescription drug coverage, long-term care. I think one of the things the pandemic also showed us is what we value, right? If you think about the impact COVID-19 had in long-term care homes, to me, that is a sign that we do not value older people in our society. So how do we shift that and start to resource those systems in a more sustained way? The last point I'm going to mention in terms of an area of investment and action is the criminal justice system. As a field, we have drawn on law enforcement to enforce a lot of the pandemic regulations, and the same lines of inequities are playing out very, very clearly in terms of COVID-19 enforcement. So how do we lend our public health voice towards systems which really promote health as opposed to systems which continue to create harm for communities? In terms of values, I think we're also seeing the importance of solidarity. And I think Pema Mazumdar is on the line. We're just finishing some work talking about some of the values which promote health equity. And we talk about love, right? And for those of you who are health promoters on the line, you recall that the Ottawa Charter in 1986 actually did talk about love as a foundational value in terms of how we organize social life. So I think just coming back to those foundational values and asking ourselves, are we developing policies at every level which are actually aligned with those values which we know actually promote health? In terms of unanswered questions, the one big one for me is, can we continue to design systems which are motivated by colonial logics and expect different outcomes? So on that note, thank you, and look forward to some of the questions you have.
Thanks, Sume. That was excellent. And they've just put in the chat box here, I think Claire O'Gorman popped it in there, the recent publication that summarizes those conversations. And Sume, you did an excellent job of summarizing those conversations from April and then pulling us along through a long and hard year to now. And love and peace were in that Ottawa Charter, and I think reminding us of those basics, I think it's a really, really important point. So thank you for that.